Dear colleague, welcome to this session, facing the challenging of resource shortages and outlook into the future of TAVI. This session is sponsored by Edwards. Here, my conflict of interest. I'm Thomas Cuisset. I'm working in Marseille, France, and I'm very happy to co-chair this session with Francesco. And as you can see, we have a great team of chatmaster with Radoslaw and speakers with Dirk, Tiffany, Simon, Alessandro, Gianni, and Cristobal. And the beauty of the team, as you will see, that we have different views from different countries. And when we speak about TAVI organization, it's key to have different perspectives. And also we have interventional cardiology and cardiac surgeon. So what was the, let's say, the rationale to build this session together? It's indeed, we face a clear challenge with the increased number of TAVI procedures in all our respective countries. So we try to think what could be the potential solution to shorten the waiting list and to optimize the TAVI organization. Probably we have three different ones. The first one is to shorten the hospital stay with earlier discharge and less patient going in the ICU between the procedure and discharge. The second one will be about optimization of the global organization, meaning about patient admission, the procedure itself, and the discharge. And finally, with a question mark, because we know that will be an emotional discussion that we will have at the end of the session, it's about the application of TAVI procedure in non-surgical centers. And following that, we decided to build this session into three different parts. So the first one is about the same-day discharge concept after TAVI, and thanks to Simon, Tiffany, and the London team, they will share the experience they had from the case performed live yesterday. For the second one, we will discuss about optimization of the TAVI organization with the result of the benchmark registry per country. And finally, we will end up with a discussion about the TAVI to be performed in centers with or without on-site cardiac surgery. So accordingly, the learning objective that we will try to achieve together during these 90 minutes will be to learn how to optimize the quality of care and patient safety even in times of limited resources, to appreciate the differences in the treatment of patients with TAVI in different European countries and understand the consequences. And finally, to discuss possible solutions to ensure the best possible patient care in the long term despite these challenges. And really during the session, please feel free to stand up. We have microphone in the room, or to send your question, and Francesco will address your questions that we will have here on the screen. And maybe just one final word before starting. At the end of the session, you will see QR code just on my back. So please scan it. And we need your input on the evaluation of the session because, of course, when we do a session in 2023, the objective from your input will be to do even better for the next edition. So I think without further introduction, sorry, Simon, you move from my right to the left. I will ask Simon to start with the first and to discuss altogether the concept of the same-day discharge after TAVI procedure. Simon.
Thank you very much. So this is a patient, I hope many of you actually saw the case. This is a case that we did yesterday morning. The patient was admitted at 7 o'clock in the morning and had their procedure as the first case of the day live to the meeting. So many of you will have seen this, so I'll go through this very briefly, but the gentleman was 82. He interestingly presented only with pre-syncope, not really much in the way of breathlessness, no chest pain. Again, not much in the way of past history. He was very fit and well, he's independent, he's active, and until recently he was walking for 45 minutes most days of the week. Bloods were unremarkable, BNP was borderline elevated at 444, and his resting ECG was normal PR interval, normal QRS interval. He had severe aortic stenosis, Vmax of 4.2 with good left ventricular function. And a CT, you probably can't read that very clearly there, but his his area derived diameter and area puts him into the 29 millimeter Sapien 3 territory, and he had very good iliofemoral access. As I mentioned, he was low risk, Euroscore less than 1, STS 1.46. So in summary, fit and well gentleman with pre-syncope, 82, no significant comorbidity, severe aortic stenosis, good left ventricular function, and he's for a Sapien 29, Sapien 3. So I've taken a couple of brief shots from the procedure because the main point of this presentation is to show the interview with the patient. But we now do all our Sapien procedures single access, at least 95% single access. We find a 3-cusp view derived from the CT and then perform an aortogram just to define in our minds where the pattern of calcification is and where it is in relation to the annulus. We then position the valve across that annulus, and you can see the calcification there. And then what we actually do in real time is we'll go back and look at the aortogram and then go forward and look at this again and probably go backwards and forwards 2 or 3 times until we're absolutely happy we've got the valve in the right position. We then deploy the valve under rapid pacing. In this case, it was at 180 beats per minute. And it's a slow, gradual deployment which would allow us to reposition if we needed to. And then we reintroduce the pigtail and perform a final aortogram, which shows no aortic regurgitation and pacing coronary arteries. ProGlide pusher. So I thought I'd just show the final steps of the procedure, and that's the closure. We introduce the 8 French angioseal. Until we see bleed back. I'll then take the long suture of the 2. And now you can let go. Now Tiffany's let go. You can see there's no bleeding. So we know it's going to work because there's no bleeding with the ProGlide pushed down over the angioseal sheath. I'll then deploy the angioseal. And you've got to be careful when you're doing this. I know many of you have done this before, but not to pull back too hard on the angioseal because there is a risk of pushing the footplate through the ProGlide. Then just check, there's still no bleeding. I'll push the ProGlide down, the suture down a bit further, lock the suture, cut it below the skin, push the ProGlide down a bit further, cut below the skin, and we're done. Now the next step that's slightly different because we've only got single access is we can't do a crossover angiogram, so we rely on the ultrasound, which is what we're showing here.
You're not doing a control angiogram here.
There we go, with colour there. You can see very nice flow in the artery.
And that's distal to the puncture site.
And I just check further down, make sure everything's okay. We've got good flow. So I'm very happy. So now's the time that we feel safe giving protamine.
You can also see there's no hematoma above the vessel.
Please. Just a little bit of oozing, probably from the soft tissues. So that procedure was completed at about 9:30 in the morning. This is on the right-hand side. I don't know how well it projects, but this is his post-procedure ECG. Again, it's normal PR interval, normal QRS. He had an echocardiogram at lunchtime, which shows a trivial paravalvular leak with a peak gradient of 20, mean gradient of 10. And now I'm just going to show a short video that I took with the patient just before he was discharged at 3 o'clock in the afternoon.
Yeah. So he came in last night to what we call the Simon Hotel. That's nothing to do with my name, I promise you. But how was it?
It was wonderful. It was all he needed. A bed, a couple of chairs, television, ensuite.
Fantastic.
And yeah, it was fine. And evening meal. And then as I was getting up early anyway, I went straight to bed about 8:30, 9 o'clock.
Fantastic. And then this morning you came up here about 7 o'clock.
That's right, yes.
We finished the procedure about 9 o'clock. It's now just after 3 o'clock. First of all, how was the procedure for you?
I hardly knew it was happening. It was busy initially, getting me prepared and you prepared, and everybody explaining what they had to do in first name terms. Very nice, very relaxed. Oh, my head's a bit. Oh, we'll get you another pillow. So they made sure I was comfortable, and I knew what you were going to do, and the jabs in the arm hurt a bit, but they don't. It's not much. But,
Good. And the top of the leg, did that hurt at all when we were doing the procedure?
no, I didn't notice that.
Good.
Didn't notice that at all.
And how have you been since?
Oh, well, fine. Yes, had to stay on the bed, lie flat, do as you're told, and you'll be all right. And nice bit of lunch, and then eventually they said, "Well, we're going to sit you up." And I said, "Well, I'd like to go out to the loo rather than use a bottle." Okay, we can try that. And that's what we did, and they just escorted me to the loo and back, and there was no wobbliness, no dizziness. That was fine.
And are your sons and daughter-in-law coming to collect you in an hour or so's time?
That's
Is that right?
Yes, they're up from Bromley.
Brilliant.
And
Okay.
so it's all worked out beautifully from the initial thought of, oh my God, I've got to be there for 7 o'clock in the morning, to, no, don't worry about that, come in the day before and you'll be home the same day.
Brilliant.
Lovely.
Okay, fantastic. Thank you so much.
Thank you, Simon.
All right, take
And
care.
if you assure me that I'll be a new man.
Thank you very much.
Yeah, thank you, Simon. I think it's really a beautiful example showing that same-day discharge can be performed, and we will discuss that probably in selected patients with optimal procedural outcome. But it's really it's opened a new field. Maybe I will see if we have questions from the audience, Francesco. And maybe while you check the question, I would like to ask Cristobal, what is in Malaga in Spain? Just to know that where you are working, I think it's important to understand that we all have different settings. What is your experience or your view on the concept of same-day discharge for TAVI patients?
Yeah, we are actually making a next day discharge, but most of patients have a one night stay, but not in general ward, but in the recovery room, and directly go home after less than 24 hours, where the next step is the same day discharge, but I think it's the same protocol, probably. The most important is the patient is able to move, and the early mobilization is a key point, because some vascular access problems appears after the mobilization. And this is a key point we keep in mind with every single patient. In Spain, it's very important the familial support. So we check it before in the TAVI nurse visit, pre-planning the same day or next day discharge. Because if the patient has not family or social support, could be a problem in the first days. Even we make a phone call in 24 hours as a control, and a present visit in 1 week with the TAVI nurse. But for our screening, we are looking for the social or family support as a key point to discharge early a patient.
So you mean you have medical but also social criteria to decide that the patient is good
Both of
candidate for
them.
that? Francesco?
Yeah, I have a question for Simon, because the first thing that comes to my mind, this is a frontier, of course. How many patients do you think are eligible for this? And how do you think this will become more and more routine, or is just really...
At the moment, I think it's a small minority. For all the reasons that we've just heard, they have to have good family support. The other problem we have, which is a particular problem for us and maybe many others, is that we have a lot of patients coming from a long way away. And in fact, he lived 70 miles away on the coast in Kent, but he had family in Greater London, which came and collected him yesterday. So I think you have to have family support. They have to not live too far away. We actually have an on-site room where we can a hotel which we can admit patients to the night before, so they only come into hospital on the morning, and I think that's also essential because they're coming 7 o'clock in the morning. And they have to be able to mobilize well. So for all these reasons, I think it's a small minority. But, we had these discussions 20 years ago with PCI. When we first started talking about day case PCI, we all thought it was madness. We all talked about PCI without on-site surgery. We thought it was complete madness, and now it's all routine. So I'm sure it's going to happen more and more over the next few years.
And among your TAVI, Simon, what is the number of patients? Less than 5%, probably? Same-day discharge?
At the moment, I think it is, yes. But I do think it will increase over time.
It will increase. Yeah. Maybe Dirk, same question about your practice on same-day discharge, and also, what about same-day admission?
So, first of all, congratulations, great case. Good to see that this is possible. However, in Germany, there are certain limitations when it comes to reimbursement, because there is a mandatory minimum length of stay of 3 days currently to get the full reimbursement. So this is a big point, because when you have the patient just for 2 days or 1 day in the hospital, you're losing significant amounts of money, which makes it a little bit prohibitive to do such a procedure. So currently in my personal practice, we are at a median length of stay of 3 days, so 72 hours. And we have a similar
For economical reason, more than medical or social.
It's a very comfortable length of stay, I would say.
Yeah.
And when it comes to distances, so where I work, we also have significant distances for the patients. So this is an issue when it comes to same-day admission. So we're having the same hurdles to overcome. And actually, there might be a cultural difference. So to convince a German patient to go into a hotel the night before might be difficult.
Francesco, do you have a question from the colleagues in the room, or maybe online?
We have a question about, technical, about the presence of a chunk of calcium that could have generated a complication. But Eric Nissen, that asked the question, also say this is probably not relevant to this session. But what I think it is relevant. I mean, what are because opening the discussion to potential complications that you think might deserve specific attention. For example, conduction disturbances. Is there, a threshold that you would?
Yeah, obviously this would only apply really to patients that either had a prior pacemaker or had no conduction disturbance and no change in conduction when you deploy the valve. But just talking about the calcium, we did notice that. We were concerned. We weren't very concerned because actually the calcium was on the leaflet, not on the annulus, and the sinuses were quite big, so we thought it was safe to go ahead and plan on same-day discharge.
Okay.
Maybe Simon, a question related to the prior pacemaker or conduction abnormalities. Do you think the concept of same-day discharge is a THV device specific to one THV device, or it can be applicable with the same safety with all the different devices? It's a difficult question.
Yeah, it's a difficult question. I think for us, we would start with SAPIEN. And once we become very comfortable with doing it, then perhaps move to self-expanding, where perhaps the pacemaker rate is slightly higher and the late pacemaker rate is slightly higher. So that would be my personal view.
Yeah.
There is another question. I think I know the answer to that, but it's important to highlight. What is the role of the nurse to get the patient home early?
Well, the nurses, we all work as a team. It's a multidisciplinary team, and the nurses are absolutely crucial, not only to getting the patient home, but managing the patient's expectations. Because if the patient expects to stay for several days, it's very difficult to then turn around and say, right, you're going home this afternoon. They have to know and they have to understand, and they have to be given lots of patient information about the procedure and about the recovery and about the follow-up, and understand that we're not, we discharged him yesterday. It doesn't mean we're not going to be in touch with him. We've been in touch with him this morning to check, and we'll call him again in a few days' time, and we keep very close contact. So, the nurses and the whole team are absolutely crucial to this.
And following that, Simon, do you agree that the success of same-day discharge also comes with preparation before? If you have proper communication with the patient, with the family, that it's doable, I think it's doable. But if you don't discuss before, if you don't do the proper information, most of the patient, exactly as Dirk said, they say, okay, I had a heart surgery today, I don't want to go home tonight. So we have really to take some time for education, to explain, and to prepare the patient and the family.
And also for the patient and the family to know that, we are not going to discharge you unless we're absolutely 100% happy and you're happy to go. And if either of those are not true, we keep them in.
Yeah, because sometimes they have the feeling that we need 3 beds, and that's why we want to discharge the patient. So
which would be the wrong reason.
Yeah, which is the wrong reason.
Yeah, I think we can conclude that it's feasible, it's safe in very selected populations, and we have also data coming from multi-center registries, of course, very selected patients, but still that have to come to be sure that this is safe enough.
And maybe, Francesco, following that, we say that it's probably, as of today, in most of our centers, less than 5% of patients.
Absolutely.
So we need also to optimize the TAVI organization, pathway, and length of stay. And that's a good transition to the next part of the session. And Dirk will present the result of the benchmark registry and to see the impact it had on the different organizations on TAVI in Europe.
Yeah, many thanks for the introduction, and it's now my great pleasure to present and maybe comment a little bit on the country-wide stratification of the benchmark registry results. So the use of TAVI optimization practices is, of course, and that's the primary result, safe and effective across the different countries. And I would like to highlight some aspects in this context. I had the opportunity to present the aggregated data of the 30-day results from the benchmark registry earlier this year in Paris at EuroPCR. And we could show that the implementation of the benchmark best practices were demonstrated to be very safe on the one hand, and they were capable to streamline the clinical pathways for patients undergoing TAVI. Just as a brief recall, the co-primary endpoints, the total length of stay, and now we are seeing completely different numbers. So it's not same-day discharge, it's not next-day discharge, but that is current practice. And that's what happened to current practice when applying the benchmark criteria. So the total length of stay in 28 centers, 7 countries, went down from 7.8 days to 5.8 days, which means a reduction of close to 25%. And also the use of what we termed intensified care beds, so it's ICU, CCU, IMC, went down from 1.9 days to 1.3 days. So both significant results for the primary endpoint. And however, the question which remained was, of course, 7 countries, what the impact of the differences in healthcare systems were. So what we aim now is to compare the data from 26 sites, so not the 28 in 7 countries, but we aim for the countries with 2 or more centers enrolling in the benchmark registry. So we compared the implementation success from these centers in France, Spain, Germany, Italy, and Austria in order to evaluate whether there were country-specific differences and potentially impacted by patient baseline characteristics, which might be difference and, of course, difference in the healthcare system, to see whether the risk-benefit ratio for streamlining such a procedure was still positive. So just as a brief review for the study design, 28 sites, 7 countries, 1,400 patients, so a large registry. Consecutive patients were enrolled, which were undergoing transfemoral TAVI with a balloon expandable device for severe symptomatic aortic stenosis. And there was a certain intervention, so there was a center education and mentoring on 8 predefined benchmark best practices and a closely monitored 2 months of implementation phase, and the patient documentation took place either before the intervention, so right in the middle of the COVID pandemic, as you can see, so 2020, 2021, and after the implementation, 1,500 patients after the implementation, so 2021 to 2023. This is the 30-day follow-up, and the 12 months follow-up is still ongoing. What were the 8 predefined benchmark best practices? It started with an education meeting and alignment of the team to have everybody on the same page within the team. That's of utmost importance when communicating with the patients. Then education of patient and family, ideally through a TAVI nurse, through a TAVI coordinator. And during this education of patient and family, there was also the determination of an anticipated discharge date at admission. So we really closely communicate with the patients that they know when they are going to be discharged. Then safety aspect, peri-procedural, echo, angiographic check of the puncture site. We've just seen that. That is important for early mobilization, which is another key point. And a clear decision tree used to determine the need for a new permanent pacemaker had to be in place. Also important, daily visit by implanter to the patient and interaction with the rest of the team. And finally, to avoid unnecessary delays due to logistic reasons, criteria-based discharge. Primary endpoints, as mentioned before, total length of stay and the use of intensified care beds on the one hand, and of similar importance, as a key secondary endpoint, 30-day safety of the implementation of the benchmark best practices. So which were the baseline characteristics throughout these 5 countries, France, Spain, Germany, and Italy? To highlight a few things, of course, due to the large cohort size, there were minor differences which were statistically significant. So when comparing, for instance, Germany with a mean age of 79.6 years to 81.6 years, there is a significant difference, but I would rather term it minor. There were some differences in the operative risk. When looking at the Euroscore 2, the range was from 3.8, which is on the low to moderate side, up to 6.8 in Germany, which is more on the higher side of the moderate operative risk. Also some variances in frailty, for instance. What were the primary endpoints? The positive result remained constant throughout almost the whole spectrum of countries. So there was a range from 21% reduction in Italy to even 35% reduction in Germany. But look at the numbers, what we're talking about. We're not talking about same-day discharge. We're not talking about next-day discharge. Germany, and this was basically the length of stay we were seeing also in the official registries nationwide, had a mean length of stay of 11.7 days at that time, but it went down just by the implementation of the benchmark best practices by 35%. But on the other hand, there's also another example, Austria, 2 centers. It might be play of chance, but there was no significant reduction. But what we were seeing in Austria, that there were lower numbers of hospital readmission. So the benchmark criteria might have kicked a little bit later in the effect. Also, the length of stay on the intensified care units was overall reduced, and it was basically driven by the reduction we saw in France and in Spain, with no significant reductions in the other 3 countries. Secondary endpoints, of course, important procedural outcomes, and what we were seeing was a strong trend towards a more minimalistic approach with local anesthesia only, plus minus conscious sedation, but still differences. 90% in Spain, 98% in Germany, and more patients in Spain, almost 40% undergoing procedure with deep sedation. And very interestingly, the differences in the procedural time, like 41 minutes in Austria, 46 minutes in Germany, and 87 minutes in Italy. I think we have to discuss it, whether it's cultural differences. I don't know, but it's hard to explain. We'll see. We'll see in the discussion. So regarding secondary endpoints, a busy slide, I have to apologize, but we tried to highlight a few things. So we used a combined endpoint to pull it a little bit together, the secondary endpoint in terms of safety, and the combined endpoint resembles closely the endpoint used in Partner 3. So it's all-cause mortality, it's stroke, and valve-related rehospitalization. And there was no significant change except in Austria, where was even a reduction of this combined endpoint. And it just maybe to highlight, in Germany, there were far less major vascular complications. That's what we're also seeing when using ultrasound-guided access and, of course, ultrasound-guided closure as well. To conclude, the benchmark best practices reduced the length of stay significantly while maintaining patient safety regardless of difference in healthcare systems and patient characteristics across Europe, with a little bit limitation in Austria, but less rehospitalizations there. Country-specific measures are being developed to enable a further optimization and refinement of the TAVI pathway. So it's an ongoing journey, that's what I think. So maybe we might end up at some point at same-day discharge or next-day discharge, but that's real-life data, what we just showed here. And adoption of streamlined hospital pathways for TAVI patients can increase, of course, hospital capacity and efficiency by freeing resources and treating patients with severe aortic stenosis. Thank you very much.
Thank you, Dirk. It's really, let's say, reassuring to see that the benchmark process was able to improve based on different backgrounds. We've seen that in Germany it's 11 days, but very few patients go in ICU, so there was quite discrepancy between the two. So it will be interesting to have the view from different countries around the table, and maybe Alessandro, you want to start, and we'll see if we have questions. Huh?
Yes, I just want to ask, it's interesting the data that you show that in Germany, it presented the longest stay in the hospital, but the shortest time in the ICU. So, and I think that this is the way to optimize the center, is the benchmark, I think, can be a good solution to optimize all the center. What was the problem for, I guess, the ward? I mean, because if you presented only 1 day in the ICU, I think is a problem of management or problem of the doctor that does not feel comfortable in discharging the patient before. Where do you improve in the management?
So there are so many factors involved. So I can report maybe some results from my center. So we implemented the benchmark criteria quite early. So we started in 2018, and we were coming from a mean length of stay of about 8 to 9 days. So we were on the lower side in Germany already, but still a very long stay. So when I would highlight a few things out of the perspective of my center when it comes to the best practices, what is important for me, to have a TAVI nurse or TAVI coordinator is absolutely key. Someone who's the most important person in the program, organizing basically everything, especially for the patients. That's one thing. You're mentioning criteria-based discharge. That is so important. When we were 5 years ago, we had the fast TAVI data presented here, and the most important reason for not having a patient discharged after 72 hours was what? Logistic reasons. And you get rid of all these logistic problems when you have criteria-based discharge and a straight pathway. So even when there's a very young resident physician on the Saturday morning, not being really sure whether he can discharge a patient or not, the criteria-based discharge will enable this younger colleague to discharge the patient and makes it even more safe. There are many, many, many more aspects, especially also peri-interventional aspects. I mentioned it, ultrasound-guided access is so important because you're getting rid of a lot of avoidable vascular complications.
Yeah, thank you. Thank you, I agree. So beside optimization, it's also about harmonization. And I think that's also the beauty of benchmark, is to say that there is so many different ways to do TAVI in a good process. And but it's true that even in our center, when we try just to skip ICU or to apply the next day discharge as the standard rule, we had to face the patient sometimes, the nurse sometimes, but also the doctor in many cases. Exactly as you say, Alessandro, we did not feel comfortable. You say, yeah, but he had TAVI yesterday. Do you think it's really safe to discharge?
It's an important part. Yeah.
You have to push, and finally it comes and it happens. Maybe Cristobal, we've seen that we had a nice improvement in Spain. So maybe you can share with us the situation in your center.
Yeah, I saw it's very interesting results, country by country. It's first time show here. And for example, in Spain, there is a more deep sedation, and this could lead to more time for intervention, and this could be an explanation for this. The good news is that only Austria is not an example, but the other countries has better outcomes after the implementation of benchmark practices. Every single country with different resources, different healthcare systems, different culture is the good news that because the logistics reasons, you can fight against it with the education of the patient, with the education of the team. It's very important to educate the team, and I would like to defend the role of the TAVI nurse as a link to be with the patient through all the journey, from the beginning to the end, till the discharge. Talking about my country, I saw that there is a higher number of frailty patients, but in the other hand is the lower Euro score. what's the point? Because probably we have for years discussing about the Euroscore doesn't reflect the real surgical risk of the patient. On the other hand, it is true that in Spain we are treating a very frailty patients. So this is very, very good information to get a deep dive there, and precisely these frailty patients should be in the future the goal for early discharge. This is where we can squeeze out the TAVI strength as a minimally invasive technique for unnecessary hospitalizations in fragile patients, because this leads to death and adverse events. And with this kind of optimization programs, you can avoid a lot of death and a lot of unnecessary hospitalizations. And this is what I learned from the benchmark registry in my hospital. Yeah.
This is an important point also to highlight, because there are data showing that patients, elderly patients, when they stay in hospital, they get more infections, they get more problems, but more complications related to the hospitalization. Please.
Okay, my name is Henrik Nissen. I'm from Odense in Denmark, and this is definitely not to brag, and I'm sure I'm not a better implanter than anybody in this room. But it just strikes me as here in 2023 we are just discussing discharge days, minimum 5. We discharge 7 out of 10 the next day. And that's not because we are specifically good implants or anything, just because from way back we just, in 2010 we've done this minimalistic stuff, discharged them to just observation ward for 1 hour and then back to the ward. So I really think there are a lot of cultural hindrances for those enormously long stays that you guys are presenting here. I simply don't understand it today. So there's, even when you did this benchmark program, I said, okay, I mean, come on. This is so irrelevant for us. And it must be for many other places here. I don't know what keeps you patient
I think
for so long.
this is a very important question to address by Dirk. It's to you. It's
for you.
No,
Please go ahead.
It's very important. Thank you for raising this, because I think it's key.
You just had a similar question.
Yeah.
I remember. That's a very, very, very good point. So you are further downstream in the journey already. So congratulations. That's very good. So that's where we want to go. But you're mentioning the cultural differences. And this is something what we are currently trying to overcome, what we're actually trying to overcome with the benchmark program. And again, it's a process. It's just what we're seeing here is a 2 months implementation, the effects of a 2 months implementation phase. And it's a journey, and we're continuing on this journey. And this has a lot to do, for instance, with also the expectations of patients and family. And the education part, you just mentioned it, the education part is so important. And it becomes so important to have a TAVI nurse, TAVI coordinator in place who starts really far upstream with the communications with patient and family, just to form and adjust the expectations. And of course, there are other things which are, I would say, I would term it a problem, which, as I mentioned earlier, that we have a virtual minimum length of stay, for instance, in Germany, which is 3 days. So in my center, we are at 3 days. So it's 72.1 hours. But it can't be less, otherwise we are losing reimbursement. It's a big hurdle, and we can't do that. So this is something what has to be adjusted politically, for instance.
But still in Germany, you ought to have a median, or maybe median stay of 3.1 day, because I mean, you must have a lot of patients who still are staying there for too many days.
I was citing the data from my center. We have started optimization earlier. So the median in Germany is far longer than 3 days. It's the minimum length of stay, which is allowed without having restrictions financially. So
yeah, but I'm just meaning that if you really had a good patient pathway, you were just being stuck by the 3 days due to the financial stuff, and then they could be left at 3.1 day.
I mean, maybe what you mentioned is that the interventional community is going too fast, and we've seen that too many times. we did radial far before having the data to support that. And I think that's also what we did with the TAVI. Finally, we have today the result of the benchmark, but it's true that in many centers, we are going even beyond that. We've seen with Simon that most of us, we are doing few patients with same-day discharge, same-day admission, next-day discharge. But I think what really benchmark provide is that it's a way, it's just a tool to improve based on your, let's say, background organization.
Yeah, that's the point. I mean, what is your starting point exactly? Because this is a picture of what is happening in many centers. There are centers that are, next day discharge for selected patients. But when we started the benchmark, several of the centers enrolling in benchmark were centers were doing general anesthesia, doing very long hospitalization. So I think the key message is that when you start implementing things, you can go in the right direction of reducing hospitalization, reducing ICU, and so on. So this is, of course, the number of days overall is not the end of the story, it's the beginning. So
yeah, fully agree. So I think we
so
can.
if you want to do a new benchmark, then start with some of the really benchmark places who have short.
But they have nothing to improve.
Yeah.
Or small improvement, but it's right.
Thanks for your input. I think it's good discussion. So maybe it's time now to move to the third part of the session. And so we've seen the same day discharge from Simon and the team in London, and then the benchmark optimization. But all that has been possible because the procedure has dramatically changed over the last 10 to 15 years. Just remember, maybe the young ones, you don't, but we start with general anesthesia, 3 femoral access, central venous line. So it sounds like cardiac surgery when you enter the cath lab, when you do TAVI in the 2008. But now it's the concept of the PCI-like, which really leads us to the next question. It's really looks like interventional cardiology. So could we do TAVI in non-surgical center? And I'm sure that will be emotional debate that we all have in our centers, country, but now it's time to have it here at PCR London Valve. So please, Gianni.
Yeah, thank you very much. It's more a guest than certainly. But I know these are my conflict of interest. I'm the study chair of the study that I will present to you in a few minutes. Of course, the current guidelines recommend the TAVI in center with surgery because there are clear advantages of that. But we have to admit that there are also some drawbacks because sometimes we are not able to offer TAVI to everybody, and that, of course, makes a waiting list. That's the reason why we designed the TREX trial. That is an all-comers prospective randomized clinical trial where patients are enrolled. And these patients are inoperable or high surgical risk, and these patients are enrolled at centers without on-site cardiac surgery. This is the flow, the study flow, where the principal investigator is one of my young colleagues, is Gianmarco Iannopollo. The inclusion criteria I will discuss with you afterward, this slide. I had to explain that these patients are enrolled at center like mine without surgery on site, and they are treated from the same operator that could be my case in this particular case, that can treat patients either at my center or at the center with heart surgery. We expect to randomize more than 1,500 of patients, and the patient will be treated in a very short time at my center without surgery. Otherwise, according to the standard waiting list, I will treat them at the center with the heart surgery. The primary point that I want to take into account also the risk of the wait. So it's a VARC endpoint, 1 year all-cause death, stroke, and hospital admission for cardiovascular causes. This is the inclusion criteria. All the patients to have a severe aortic stenosis, and they have to be judged deemed for transfemoral TAVI from the heart team with the surgeon. And this step is done 2 times. Before, the first time to know if the patient has indication for TAVI, the second time if the patient has indication for enrollment. These are inoperable patients or patients with heart surgical risk or other features that increase the benefit risk ratio of emergent cardiac surgery. Could be older age, more than 85, severe renal dysfunction, or a severe pulmonary disease or intervention. This endpoint The primary efficacy endpoint is the cumulative on 1 year occurrence of all cardiac death, stroke, and hospital readmission. But we have also a primary safety endpoint that is death in the first 3 days due to procedural complication actionable by emergent cardiac surgery. That means that the patient would have been treated in a center with heart surgery, would have had less risk than to be treated at my center. This is the trial status. We enrolled the first patient in the middle of July. We already enrolled almost 40 patients, and 16 patients have been already treated at center without surgery on site. We had a grant, also research grant from our national health system, because this study is believed to be a change-promoting study. So these are the background. I would like to show you the first cases that was done at our center. This is a pretty straightforward case. He's a 85-year-old male. He's very fit, normal size. He's very active. He likes to fix the car, and he still drives the car. He has risk factors like former smoke, hypertension, dyslipidemia. He underwent right carotid endarterectomy some years before, but his cardiac history starts this spring when he had exercise angina. And finally, he was diagnosed to have a severe aortic stenosis with high gradient normal flow, and also a severe three-vessel disease that was treated with multi-vessel PCI. You see also the left main and LAD, RICA, and LCX. But at the end of August, we discussed the case with Alessandro Leone and his co-workers, and the patient has an indication to TAVI. So we decided to, afterward, to enroll it in the trial. This is the anatomical data and the procedural data. You see it's a pretty straightforward procedure. There are very few calcium in the annulus. The valve area is 422, so it accommodates 23 size Sapien valve. The coronary sinus are pretty large, and also the sinotubular junction is normal. You see also the coronary artery are pretty high, and you see the stent in the left main that is not protruding in the aorta. You see also the peripheral vessel okay with very few calcium and very few tortuosity, and the vessel size is reasonable. Therefore, we plan the procedure according to the standard of care at our network with Francesco. Is a minimalistic approach, local anesthesia, just the left radial for angio and the right femoral access for TAVI. We stitched the groin with ultrasound guiding puncture, and we decided to implant a Sapien Ultra 23, in this case with the pacing on wire, and to get hemostasis with the pre-implanted ProGlide. So let me see the case, just for first case. This was done at our cath lab at Maggiore Hospital. You see Giampiero Nobili, who is in the arena here, that is stitching the groin with the aid of blue ultrasound. So nothing special for you that are very expert interventionalists, but you see that how we work. So just to have an idea where the stitch if is was correct. Then here's the valve and the tricuspid valve. But you see the stent on the left main.
Where is the pigtail? Where is the pigtail?
Also, one operator of the Ferrara Hospital that joined us because we work as a network together. If you like, afterward, we could discuss this kind of organization. So, of course, it takes some minutes to go inside, but that So we put the wire. We test the pacing. We had a gradient about 50 before. There's a valve. And of course, to achieve this, to perform this case, we have to have the careful training of also our nurse technician and also the people of the ward on the intensive care to deal with this case. So this. So we advanced the VAS, and I guess we are ready to deploy it. Okay. The patient is awake. He had just a local anesthesia, no sedation, and nothing else. So, okay. We retrieved the system, and I did the result. There was no gradient afterward. And so also with the echocardiography, there was no aortic regurgitation. That's Giampiero Nobile who is talking with the patient, and after a short discussion, I guess we closed the groin with the triple glide, and there were no problems. Also, you see, the occlusion was perfect. So we had also a brief interview of the patient that was done afterward.
Come è andata oggi? È stata dura un pochino, eh?
È andata bene, mi sono trovato bene. Non ho avuto dei grandi disturbi.
Non ha avuto male, non ha sentito male?
No, non ho avuto problemi. Sì, qualche più che altro era più la tensione che il dolore, era più la paura che il dolore, insomma.
Un po' di batticuore l'ha sentita.
Non c'era motivo, perché poi alla fine dei conti mi sono trovato bene, insomma, ecco.
Perfetto. Mi racconta un pochettino qual era il disturbo che sentiva nei mesi scorsi?
Dunque,
I don't want to bother you with the presentation, but the presentation, the patient said that he's very happy and he was a little bit fearful, but now it's okay. And his target is to fix again the car, and I swear that he did, because we follow up him 2 days ago, and he's in a perfect condition, and he already did the gardening and whatever. So I think I could end up my presentation right away.
Thank you, Gianni. I think it's a beautiful example of TAVI performed in non-surgical center. It's a straightforward case, but as we know, sometimes we have more challenging patient, more challenging anatomy, and I think that's probably why we need to see a second case from Francesco and your team.
Yes, thank you, and thanks, Gianni. We worked together for a few years for the training and so on, for setting up the network. But what I will show you is a patient that, in my opinion, is still very important to treat in a center with on-site cardiac surgery. This is a male, 80 years old. You can see that is very active patients and fit, recently developed symptoms. This patient has a bicuspid aortic valve. Not relevant comorbidity, you can see, and low STS score. Echocardiogram, no normal left ventricular ejection fraction. You can see very high gradient, so 0.78 centimeter square area. So severe aortic stenosis symptomatic. Coronary, no disease. In terms of annular dimension, this is an area of 460, which is compatible with a Sapien 26 millimeters. I can show you a little bit something that, confirming the bicuspid anatomy is a type 1 L2R configuration. You can see what this is the plane of the raphe. Raphe is not calcific that much, but you can see there is a calcification protruding, and the LVOT is quite bulky calcification, so it can raise some concern. Coronary are, not too high, but okay, because considering that there are very large sinuses, you can see here on the right confirming that there is a lot of calcium, but the raphe is not very calcific. So this is the aorta, a little bit of tortuosity, certainly, but this is the evaluation that we do. We all know about bicuspid valves. We did a simulation. Everybody has his own preference, but basically you have to consider what is the measure at the level of the annulus and the level of the raphe. Then you can put a virtual valve or Silkor method. Anyway, our considerations overall ended up with a choice to implant a 26 millimeter Sapien Ultra valve. There is, as I said, nothing relevant in terms of vascular access. They were large, despite some calcification. So this was our procedural plan. Sapien 3, 26 millimeter, local anesthesia, patient fully awake, echo-guided vascular access, secondary access radial, which is our standard of care since many years now, temporary pacemaker in this case, because this patient I didn't mention had already an important baseline conduction disturbance, so different from what I do normally. I decided to implant a temporary pacemaker. No CCU after the procedure. This is also standard of care at our center. Early mobilization, 6 hours, and discharge. So this is the procedure. You will see nothing special really, but this is our setting, hybrid room. We have no anesthesiologist in the room, and this is not, again, something new. It's 15 years that we don't have. We have a protocol with the anesthesiologists that are not in the room. Patient is fully awake, so no sedation at all unless they require it, no urinary catheter. We avoid everything that is unnecessary. So radial access, this is, in this case, as I mentioned, I put a temporary pacemaker, and you will see that this was the right choice. Echo-guided vascular puncture. Maybe I can also go a little bit faster in some, so we can save some time for the discussion. But, there are some points that may be relevant. Working without the anesthesiologist means that the nurse is more and more involved, is our true anesthesiologist, in talking all the time to the patient that is fully awake. So it's very important to keep the contact constantly with the patients. Okay, we use the two-proglide technique. I go a little bit faster. This is the pigtail coming from the radial. Finding the coplanar view. So you can see here, we saved some contrast, but this is a good coplanar view. The big sheath, the E sheath. Go a little bit faster. So this is the crossing of the valve. Once we crossed the valve, the patient developed complete AV block. That was he had already, as I mentioned, a major conduction disturbance up front. So having the pacemaker on board was the right choice. But again, okay, then it's positioning of the wire. You see AV block. And, just to highlight also the fact that those people who are working with me, those are 2 young fellows. So the procedures now is very simplified in every aspect.
Where are you?
Okay, so this is, these steps to realign the balloon with the valve. You remember that there was an important tortuosity of the aorta, but this did not generate any issue in this patient. And this is while we cross the valve. I think it's very important in the bicuspid valve to be, in every patient, but especially in the bicuspid, to find the right spot where to cross. I mean, I don't push ever the valve. I don't like to do that. I never predilate, almost never. And it's just a matter of finding the right position. You see, I spent a little bit of time just to find the position and let the valve go in without any pushing, because we know that some people is concerned with the cerebral protection or potential of cerebral embolization in bicuspid valve. So this was a smooth transition, and then the implantation of the valve. I was very curious to see, Simon, your implantation without angio. That was very interesting. I never tried that, but I think this...
But we don't do it for bicuspids.
Okay. Yeah. You see, complete AV block, but we were there. And then I go rapidly to the end of the procedure. What we do, we just remove the pigtail and position the pigtail in the descending aorta. Here, okay, we are checking the gradient, and this is the final results in terms of gradient. In terms of angiography, you can see there is no leak, no problem with the hemodynamics of the patient. Then you just move the pigtail down. You see again the tortuosity of the aorta, and then we close with the double proglide. And then we check the final angio regularly, either angio or we use, in patient with kidney disease, we use CO2 angiography or echo. So, thank you very much. I think I saved some time for the discussion.
Yeah, thank you, Francesco. That's nice, because I'm sure we'll have a lot of comment and question from the room. So we had two nice cases to set the stage, one straightforward in non-surgical center and one more complex performed in surgical center, but maybe without surgeon in the room. We'll discuss that after. So we'll now have two short presentations for the pro and cons to do TAVI in non-surgical center. And after, of course, we will open the discussion with the panel and with you in the room. Please, Jenny.
Again, I take the pro position because I will have a wise position, I guess. So again, the recommendation, the guideline recommendation stated that TAVI is recommended in patients older than 75 years old. That has a very important drawbacks because TAVI needs to skyrocket. So this could be a problem in country like us, where we have a universalistic system, and also generate a huge waiting list. The waiting list by itself is a risk. We know data from Ontario at the beginning of last decades that stated that if a patient waits for more than 3 months, it has a 2% chance of mortality, at 12% to be admitted. But also we have newer data from the same countries that confirm the same position, although the number have increased of procedure, but also the waiting list has become longer in this way. This poses a big problem, especially in countries like mine. We live in a region, the Emilia-Romagna region, with 4 million inhabitants. We have 4 TAVI networks working with the surgery on site, and we have 10 very active interventional centers where we perform, on average, more than 1,000 in primary PCI every year. So on average, we have 200 TAVI for million people, but we have to expect it to increase to 400. But also with this, the current number, we have a very long waiting list, and in 2021, only 30% of our patients had the TAVI within 3 months. So we have to expect a lot of events in this case. So what are the ways to improve our way of meeting the needs of the patient? There's a very outstanding paper from Ali that presents the Valve for Life project of UK that stated that one reason could be to optimize activity of existing heart valve centers. Of course, this is very efficient. There's a lot of experience, but probably the center should not be able to deal with all these cases that they need. The other is to increase the number of heart surgery centers to perform more TAVI. Could be not very cost effective. The third point, but they should be very tightly regulated, is to start TAVI programs in center without on-site heart surgery. So let's review a few points. What is the risk of a patient undergoing TAVI today to have a catastrophe and to need emergent surgery? To be honest, the risk is very low. We have data from a very important center that underline that the risk is below 0.5%. Other centers are around 1%. But we see that the risk with the standardization of the procedure and the better material that we have is going down. But also we know that if the patient runs into troubles and needs emergency surgery, he has a very high risk of dying during this surgery, especially if it's very old and if it has a lot of comorbidities, like you see in the right way. So is it feasible to have TAVI in center without surgery? There are already limited experience, mainly for registry data in a country like Germany, Austria, and Spain that say that it is feasible, and also results are comparable, so patient may be a little bit more complicated. And also there are also concepts in favor of that. Of course, there are problems because we have to admit that there's a very high risk to have a suboptimal evaluation through an art team of the patient, and we had to be very careful that this not happen. But probably to perform TAVI in center without surgery could shorten the waiting list for TAVI and have less event on the wait, could improve the proximity of treatment of this patient, but to my opinion also need to increase a lot the competence of the spoke center. But to my opinion, there are three key points that should be observed and documented before start a program like this. First of all, we need a careful selection of the patient by the art team, so the role of the surgeon is very important. First, as I said before, just to state that the patient has indication for TAVI, and then that the patient is suitable for TAVI in a center without surgery, because the chance to have emergent surgery is low, or in case of he would not have emergent surgery even in a center with the surgery inside. The second point is that we need have high expertise of the center of the operator. First of all, we need programs and cooperation with the surgeon. Secondly, we need very experience in TAVI management, in advanced imaging management. Secondly, we need to have a vascular surgery inside and also an EP lab. And of course, the operator should be very skilled interventionalists that are able to manage all the tools that are necessary in case they run into complication. They have to be trained in a center with heart surgery inside, like we did. And also they should have a reasonable number of TAVI procedures yearly to maintain their competence. But the third and mainly the most important issue is that you need to network with the Heart Valve Center. We have a strong cooperation with Francesco and our friends of the network. So we share patients together. We have shared the training. We have been trained there. We share indication to TAVI, and also the management is the same to guarantee that there's equal access to TAVI to everybody, and also that the results are comparable. So to my opinion, now the increased need of TAVI needs to reconsider the current organization. We have seen today a lot of options that could be reasonable. The heart surgery team has a key role in patient selection and procedural planning, but I don't believe that the role as a backup to TAVI is very limited. It's a very particular case. TAVI availability should be increased to limit inequalities and the risk of events while on the wait, but therefore I feel that TAVI without on-site heart surgery could represent a study hypothesis for an expert heart valve network. Thank you very much.
Thank you, Gianni. Very, very convincing, but still we need to hear Alessandro. We will probably balance a little bit this view, I think.
Yes, I just grouped all my questions to this presentation, and as playing the role of the counterpart, I wish first to thank all the committee for the kind invitation. It's a privilege and honor for me to be here. I have no conflict to report. This is what can happen in the real life. I mean, I want just to show you some picture of the real life. This is a lesion of the guide wire that happened personally to me, and I had to repair with a patch, double Teflon patch on the ventricular wall. This is a lesion reported in the literature of the LVOT that was repaired with a patch on the LVOT. This is just to know something really difficult and very difficult to repair. This is a type E dissection that happened in our center during the passage of the delivery system in the aortic arch. And this is something that happened also to us. This is a migration of valve during a valving ring, mitral valving ring procedure. The valve was migrated in the aortic arch, then was realigned and fixed with the open stent in the aortic arch. Now, I want to, just after this show, discuss with you some consideration. First one is, we know very well that emergency cardiac surgery after TAVI is very low incidence, 0.7%. And we know very well which one is the best, which one is the worst case. But the mortality rate is, in-hospital mortality rate is 46%. And if we compare with emergency cardiac surgery after PCI, we are comparing, in my personal opinion, apple with orange, because we have a rate of 0.2% in the PCI, but the mortality is completely different. The mortality rate after TAVI requiring cardiac surgery is 46%. So if we make another consideration, nowadays, across the Europe, the heart team discussion is always performed in 50% of the case, mostly. And in the 30% of the case is the majority of cases performed. Majority, I have to understand what is the majority. Third consideration, we are speaking about mortality rate during the waiting list. In the waiting list is 5.2% in the TAVI population. But as we can see from the baseline characteristics, they are totally different population, TAVI and surgical AVR. The population of the surgical AVR nowadays can be considered as an intermediate or at least low-profile risk patient. So if we totally agree that the mortality rate in waiting list for TAVI population is extremely high, we have to understand also that the mortality rate for the low-risk profile patient is quite overlapping the mortality risk during the procedure. So this concept of the mortality risk for the low-profile patient is partially falling apart. Last but not least for importance is the guidelines. Guidelines that just go straight forward for the mitral surgery, for the mitral therapies to heart valve center. Science, we have all the figure that can treat all the mitral for all different type of surgery, of repair, and all different kind of treatment. The same concept has been now standardized from the last guidelines, because the heart valve center need to present some key figure and some key characteristics, starting from cardiologist, cardiac surgeon, imaging professionist, and so everybody has to cooperate in order to guarantee the optimum outcome for the patient. Especially if we consider that in the next future we are facing new challenge with new devices that are coming out. So I will just leave you and conclude it with some question. If we open the TAVI to all center, will the heart team perform as recommended in all center without on-site cardiac surgery? Will the TAVI cases present the same risk profile as in center with on-site cardiac surgery? In the future, how the operative risk will be discussed with the low-profile patient? And least but not last, what the meaning, given all of this, of the heart valve center? Thank you very much.
Thank you, Alessandro. I'm sure Francesco will have many questions coming from the audience. Maybe I will start just with Gianni regarding the TRACS study, which will provide very interesting data. But maybe because we've seen that you say that in TRACS it will be high-risk, inoperable patient, but you share with us, let's say, a straightforward TAVI. So the real question from the TRACS and applicability to our practice will be which you think is the ideal patient to be performed in non-surgical center. And you say in TRACS it will be the same operator in both, but in real life I will never go in non-surgical center 50 kilometers away from my hospital to do the TAVI. That will never happen. So how do you see that, meaning the TRACS criteria and applicability into clinical practice?
We feel that, you know, the design of this trial was started because we do several patients that we are more, let's say, older than 85 years old, that at least in our practice are not operated. There's no chance to be undergo a surgical intervention. We perform at the Hub Center in a conventional cath lab. And and I am the same operator that I've been trained over there. And I'm sure that you should never move to a spoke center. But of course, if you have a very effective network like we do, for us it's a change because maybe we could select a patient that reasonably should not be operated in case of troubles to be performed at our center. And then you have more room in the main center to have complex cases of very low-risk patient. I don't believe that you will never treat a very low-risk patient or young, 75 years old at my center. This is not my target. My target is to reduce the pressure toward the heart valve big center, so to let time for these people, for my colleagues to treat the mitral, to implant mitral valve and to do other procedures that should be never performed in my case. Of course, I have a very big advantage because the competence of my center rise up a lot because we deal with the large bore introducer, we deal with vascular complication and also with the imaging.
Okay. Francesco, do you have a question from the audience?
No, first, you know, I want just to elaborate a little bit on this because I think Gianni showed very well what is the background. I mean, the background is, you know, we need to increase the number of TAVI. Countries are different, regions are different, possibilities are different. So, number one, increasing heart valve centers is said. So, my question to Gianni and to who wants to address that is, I mean, in an ideal world in which you don't have any waiting list on the heart valve center, do you think that there is still a good reason to do TAVI without on-site cardiac surgery? Because we know that there are centers declaring zero waiting list, so or very short waiting list.
Cristobal, maybe. Cristobal, yes, please.
Yeah, probably we have talked about the problem of accessibility. The patient in far away from a hospital, a heart valve center, could be less access to the TAVI or any other treatment. Overall, if we are talking about old patients, and we are working with 80 to 90 years old patient that sometimes refuses to go to another city for undergo treatment. I think the accessibility is open when you take this option of opening another TAVI programs without surgeries on site.
Simon? Maybe this question is ongoing in France, and we try to define which is the good threshold to define that the center is doing enough TAVI. We've seen in your slide that it will be 20 TAVI a year, which means one TAVI every 2 weeks and a half. What do you think about this threshold? But we have exactly the same discussion nowadays in France.
I think that's the key. And the key to this trial is that it's the same operators that are going out to the non-surgical center. And I mean, certainly in the UK, and I suspect in many places of the world, you know, interventional cardiologists are mavericks, and they will look and they will see a low-risk case and say, oh yeah, I can, you know, they'll see a live transmission and say, I can do that. And they'll think they can just go and take that sort of patient and treat them in a non-surgical center, and there'll be low-volume TAVI operators. You know, a high-volume TAVI operator, such as one of us, you know, we could do a successful TAVI with an image intensifier. You could do it in the toilet. It doesn't matter. You know, you don't need on-cars. What you do need is you need an extremely experienced TAVI operator doing your procedure and able to bail out, able to analyze the CT, know that they're low risk of annular rupture, low risk of coronary obstruction, low risk of a vascular complication, and be able to deal with that vascular complication if it occurs. And the reality is that's not what's going to happen. You're going to get people who have been trained in PCI but not in large bore access, not in TAVI, thinking, you know, the guidelines now say we can do TAVI in a non-cardiac center, so we're just going to start doing it. And I think but that's my real worry. If that happens, it'll be chaos.
Yeah. Agree, Dirk. Maybe following this point, we always, and we've seen with Alessandro that we have the concept of emergency cardiac surgery, but the rate is very low, it's less than 1%. But we discussed a lot about the procedure itself. But don't you think that the main risk, as Simon said, will be about the indication? Because as a community, we have to learn from what we've seen for the PCI story. And do you think we might face exactly the same issue if we open the Pandora box for the TAVI cases?
I think that's the point. So many things come into my mind when discussing this topic. So selection might lead, of course, to a lower caseload. And I think what Simon just mentioned, experience is key in this context. So we have, of course, this discussion as well in Germany going on. However, in Germany, we have the situation that there is something like a law-like regulation which does not allow centers without having cardiac surgery on site to perform TAVIs if they want reimbursement. And I guess there are also legal issues after that in that context. So I think key is, of course, the caseload, and the caseload needs to be high for every single operator, and otherwise we might face similar problems.
Yeah, I think it's important here to highlight the fact that, going in the direction of your comment, that we are not talking here about, promoting these kind of things. I mean, we are simply talking about research, because the TRACS is a research protocol. There is another, for example, a study also in Italy approved with this by an ethics committee with a different design, is a registry, but still. So at the moment, I think, all the concerns are reasonable, because, what Simon said, experience, and, what is the threshold, how many TAVI do you have to do or to perform regularly to have, it's like in PCI, the more experience you have, theoretically, the best you are in doing the procedure. So there are many issues, but I think, research is good, that we have, investigate hypotheses and generate hypotheses, and we will see.
And maybe following that, maybe one question for you, Gianni. It's we see also that interventional cardiology has changed in the last 10, 15 years. Now we do probably half coronary, half structural. And also to promote TAVI non-surgical center, it's also, as we discussed with our colleagues from those centers, a way to keep attracting young guys to go and work in these centers, because they say also that it's unfair. How could we attract young physician fellows if we just do coronary? What do you think?
This is a big issue, because I am a director of the big cardiology center, but if we do not perform a structural intervention, sometimes I have problems in recruiting young doctors. But also, I think that it should be correct, because this doctor miss a lot of the story of cardiology right now, to the miscompetence in, let's say, imaging that are very important. So this is some kind to promote. Coming a little bit back, I would say that I don't feel, I was trained in Germany 30 years ago in a center without heart surgery. So, and I always work in a big center without surgery. So I think we need a cultural backup of the surgeon, and also to the improvement that they bring us with their skillness, but not. I don't feel the need to have the surgeon here, because if I treat this kind of partner A or partner B patient, many of these cases should not be treated. The surgeon by himself will refuse it to treat it.
Yeah. Francesco, maybe will give one word to the cardiac surgeon of the team.
Absolutely, I think we have
That's
to.
all the question that I...
But first of all, highlight the fact that it's part of the team.
Of course, it's part of the team.
Just to be clear, part of the team, part of the tracks. I work together with Francesco, so even in the cath lab. So, the problem is a problem of our team is the most important thing above all, in my opinion, because you can even decide to open the TAVI program in different center, but then it is difficult to organize for each center a proper art team. I mean, I think that there is a risk in the future that the art team will not present the proper characteristics as we know today. First. Second is the Heart Valve Center. So, Heart Valve Center has not been established by me, by us, but the guidelines from the ESC Society, from the ACTS, in US and in Europe. So, if we need of Heart Valve Centers, be a reason, I think, and the reason is behind all the study on the randomized trial that we already know. If we consider that in the future we are facing real different strategy and device, how can we copy with that? I mean, in the future. I mean, why Dr. Casella, that is in his right, feel to have the right to do the TAVI, why not even the Evoke? Why not even the? Is he right? I mean, I'm in. So,
Alessandro, I want a little bit to interact about that because, not to support, because again, I'm not supporting, something. I think it's a matter of numbers that also makes the difference because when, for example, we deal with, 300, 400 TAVI per year is our number, okay? We can increase to 600s, but we need 800s, okay? That's an example. This is a story we can tell and we will see what happens. When we discuss about mitral, tricuspid, we are dealing with small numbers, patients that necessitates more selection, more discussion, multidisciplinary, the transplant people, other people. So I think in this moment there is an important still reason to keep this patient treated in the hospital with on-site cardiac surgery. So I think I would not open the discussion now, today, in the current situation for the other yeah.
Indeed, we won't. So maybe just to summarize, so we say that just in few words that the TAVI numbers will increase because the indication really expanding thanks to the recent evidence and in practice. So the risk is to increase the waiting lists, and we have different options to try to overcome this challenge. One is the same-day discharge that we've seen nicely during the case of Simon and Tiffany, but we say that it will be really, let's say, for selected and limited number of patients. So beside that, we have to optimize, and we make the procedure as simple as possible. So we have to optimize the TAVI pathway to shorten the hospital stay. It's true that you did great in benchmark, but as we heard from one of our colleagues, we can probably go even further and reduce the hospital stay. We probably have to discuss with the German authority to change these rules to keep the patient 3 days. We had the same few months ago in France. Good luck for that. And the next question is to know if we optimize everything in the Heart Valve Center. After the next discussion, and we see that it's a lot of not emotion but different opinion, and I think we can discuss hours about that to know whether we should do TAVI or not in non-surgical center, and which operator, which is the good volume. Should we do 20, 50, 100? I don't know. Which is the ideal patient to be performed in non-surgical center? That's also what we learn from the ongoing studies and from the experience we will collect. So saying that, just you see here on the screen is just a QR code to do the evaluation of the session. That will be really useful for us to try to improve again what we will do next. And I would just like to close the session by thanking Edwards, of course, Francesco and all the speakers. I think we had a great discussion, and thank you for your input during the session. Thank you very much. Bye-bye.
Thank you.